Bismillahirrahmanirrahim. Hello, everybody. Welcome again to Ziada Academy. Today, we'll talk about one of the commonest causes of infective keratitis, which is viral keratitis. The viral keratitis, actually, no financial disclosure for this presentation, just to announce again for my YouTube channel, Ziada Academy. Please subscribe and share to find our new videos. So the viral keratitis, which is also called the epithelial keratitis, is the commonest cause of infective keratitis in developed countries. The common viruses in this entity is herpes simplex virus, type 1 or type 2, but type 1 is more than the type 2, especially in the adults. Also the varicella zoster and the herpes zoster ophthalmicus. The adenoviral keratitis is also common, but it's not common like the herpetic keratitis. The thiogenic keratitis, also the added COVID viral keratitis in the pandemic. The dendritic ulcer actually caused by the herpes simplex virus. Actually, the herpes simplex virus is DNA virus, and the humans are the only natural reservoir for these viruses, especially after the primary infection, which commonly occurs during the childhood with the primary infection of the eye and conjunctivitis, keratitis, and skin disease. Ocular infection occurs as primary or recurrent episodes. The epithelial keratitis is related mainly to the direct effect of the virus itself. Means that the reaction of the epithelial cells to the virus antigens are virus toxins, and the reaction of the virus inside of the cells leads to epithelial changes or epithelial defects, forming the dendrite. So epithelial keratitis is synonym to the herpetic keratitis due to the direct effect of the virus itself on these epithelial cells. Stromal comorbidity is related to the CD4 and T cell destruction. It's an immune inflammatory response to the virus, but the primary affection is related to the epithelium, and it may be associated with a stromal affection or not. In this table, you will find that there is a prevalence and incidence of the herpes simplex virus keratitis, which is roughly 1.5 million, including 40,000 new cases of severe monocular visual impairment or blindness each year. I think it's much different now because it's old statistics. This is the form of the dendritic ulcer with the different types of presentations. In the upper photos A and B. B is a diffuse punctate epithelial erosions or punctate superficial keratitis, which is one of the modes of presentation, or the early signs of the viral keratitis could present first with this diffuse punctate epithelial erosion, which may be mistaken for another disease like severe dry eye or filamentary keratitis, which occur in other autoimmune diseases, but it could be one of the modes of presentation of the viral keratitis. Okay, so on the left side, the photo number A, the photo assigned with a letter. This is the classic presentation of the viral keratitis, which is the dendrite with branching lines and especially with Ross-Bengal test, you will find that there is a terminal bulbs, which are the virus-laden cells. Down here is the geographical ulcer, severe form or mistreated viral keratitis, especially in the immunocompromised patients or with co-ocular surface morbidities, as well as after mistreatment with steroid. The primary infection could be like in these pictures with congenital or neonatal due to birth canal infection, or congenital during the gestational time with a mother infection with herpes simplex virus, or neonatal due to infection with the herpes simplex type 2 during passing through the birth canal in infected mothers. Primary ocular infection, also recurrent ocular infection after that. All these figures are different types of herpetic disease. With a microdendrite, PSK or PEE, also serpiginous epithelial defects. Topical and systemic acyclovir with ointment 3% or intravenous acyclovir in the neonatal infections, severe infection specifically, as 2 grams per day for 2 weeks. Also, the cellular and humoral immunity leads to this destructive changes in the cells, either in the skin or in the eye. The response actually due to the virus itself. Typical and atypical presentation in adults ocular herpes, especially they are commonly the secondary infection, not the primary infection. So is peripheral conjunctivitis. Peripheral conjunctivitis may be in the primary infection or the secondary infection as well, with vesicles and pustules on the skin of the eyelids, also with the conjunctivitis with or without keratitis. Maybe with episcleritis or scleritis in severe disease, especially including the uveal tract. Corneal keratitis in the form of epithelial keratitis, infectious ulcerative keratitis, trophic, or metaherpetic ulceration. This is the severe form of herpetic keratitis with loss of the corneal sensation. Stromal keratitis, like necrotizing, non-necrotizing keratitis, deciform, diffuse, or linear keratitis. The less common presentation of endotheliitis, especially with that of the combined uveitis and herpetic uveitis and keratitis are the same, with iridocyclitis and trabeculitis, which is the miserable and the most dangerous form of viral uveitis and keratitis at the same time. Here we will emphasize on the corneal disease. Clinical course and signs in the form of diffuse punctate epithelial erosion as a start, then 12-24 hours after cell nuclei became laden with replicating virus, then cells swell up. This will be assigned with the positive fluorescein stain, as you see in the picture in the middle. Also in the upper photos, this is the punctate epithelial keratitis. And here on the right side, this is the rose Bengal stain of the dendrite. In the middle, the fluorescein stain, and in the bottom, the photo shows the rose Bengal stain for the classic dendrite, staining the branches, the lines, the core of the dendrite, also the terminal bulbs of the dendrites, staining the virus-laden cells. Characteristic branching line with terminal bulbs. This is the characteristic dendrite of the viral keratitis. Also, marginal or limbal disease are more symptomatic. In this case, you will find that the patient will suffer of a significant pain in spite of affection of the corneal sensation. But here, the limbal part and scleral part of the infection will explain this severe pain. Decreased corneal sensation is one of the landmarks and the characters of the viral keratitis. So you have to check for tip the cornea and touch the cornea to check for the corneal sensation in such cases. Amoeboid ulcer, which may be mistaken for amoeboid ulcer, mistaken for acanthamoebic keratitis. So you have to differentiate between both. Severe pain with less signs, acanthamoeba, contact lens wearer, acanthamoeba, woody or wet vegetables or woods, maybe acanthamoeba or fungal. But if there is no history, if there is minute lesion with less pain, think about the viral keratitis and follow to find the dendrite and the response to the proposed treatment, assumption-based treatment until you get the correct way. Sickly, as the all types of keratitis, there is a sickly or scenario, which depends upon the diagnosis and treatment. Persistent keratopathy, recurrent corneal erosion, persistent epithelial defect, yeah. But actually, you can help stoppage of this pathology, of these pathological changes by the early treatment and the correct and proper therapies for this viral keratitis. But put in your mind that the epithelial defect in such cases will be first due to the viral keratitis, then after long-term therapy for the epithelial toxicity from the drugs. So you have to check for the cure and recovery from the virus, then try to treat and to help healing of the epithelial defect, which is left behind the viral keratitis or the ulcer itself. What about the stromal keratitis? It's 2% with primary and 20% in recurrent cases. And it may be severe, like shown in the photo. Up on the left side of the upper photos, you'll find that there is severe thinning and melting and going to perforate the cornea. On the right side, on the right photo, right up photo, you'll find that there is just stromal haze and going to be scarred, but with thickening. There is no thinning, as you see in the light in the slit lamp section, but with intact epithelium in this case. After a time of treatment, the stromal keratitis is superadded infection, which may be superadded infection with the stromal with a virus, could be with bacterial or fungal infection, according to the circumstances and situation. So it increases the incidence of getting corneal perforation in such a disease, or added autoimmune keratitis or immune reaction with vascularization and opacity, as shown in the down photos. Deciform keratitis could be mistaken for the autoimmune keratitis, like the Cogan syndrome, Cogan disease, and you have to differentiate from the sequence and history of this disease. Here, the differential diagnosis, look at the photo, the upper photo and the down photos. The upper photo is infectious, but the down photos with infiltrates, and it acquires the pattern of the deciform keratitis of the autoimmune diseases, which is related to the uveal tract inflammations, like with iritis, with iridocyclitis, with Postner-Scholzmann syndrome or Cogan disease. Endothelitis is very rare, but there is demarcation line between the edematous and the non-edematous areas, and this patient should present with uveal tract affection with the virus, with the herpes simplex virus. Also here are the complications with iridocyclitis and trabeculitis, and they are severe case with very bad prognosis and should be aggressively treated with the systemic and topical treatments. Herpes zoster ophthalmicus, varicella zoster virus, you can find it elsewhere than the common presentation with the herpes simplex, but should be associated with skin disease, the herpes zoster ophthalmicus, including the distribution of the ophthalmic nerves. So the eye is usually affected when the tip of the nose is included with the affection in herpes zoster ophthalmicus. One of the landmarks and the characteristic signs. The tip of the nose as shown in the figure on the right side is one of the signs of ocular infection with herpes zoster ophthalmicus. Let's go for the treatment options, either medical or surgical. The medical is also either topical and systemic, but actually I prefer to start with both together, but the systemic therapy is the dose of the systemic therapy is defined according to the severity of the disease and extension of the disease. But anyway, we will start with the antiviral cyclovir, which is a cyclic analog of guanosine. It acts by inhibition of the DNA polymerase following phosphorylation, or actually this word, there's a mistyping. The correct word is phosphorylation by viral thymidine kinase, which is effective in infected cells. It's safe and effective against herpes, herpes simplex virus, varicella zoster, but not against this cytomegalovirus. Its half-life is 5 hours, so the dose should be 1 tablet of 400 milligrams per 5 hours for 3 weeks. During treatment, then turn to prophylaxis. The side effect could be headache, renal insufficiency, and GIT disturbances. The second drug is ganciclovir. It's a cyclic nucleotide analog. It's an inhibitor of herpes virus. herpes simplex and varicella zoster, and the cytomegalovirus DNA polymerase as well. Also false substrate for the cytomegalovirus and DNA. So it's effective in treatment of both herpes virus and cytomegalovirus, but more effective in treatment of cytomegalovirus than acyclovir. So it's used as the drug of choice in viral retinitis, which is caused usually with the cytomegalovirus. Systemic and intravenous and intravitreal injections as well. Side effects: neutropenia, thrombocytopenia, and renal impairment. So with the cyclovir or generally the antiviral therapies, you have to check for the renal functions and follow up them with the lab. You can add also supplementary treatments like the multivitamins, antioxidants, immunomodulators, analgesics. Also correct the general predisposing factors like diabetes mellitus, psychological disturbances, and extra. Topical treatment. It's most important in the limited epithelial keratitis. Acyclovir and ganciclovir, both of them, eye drops and ions. It's used 5 times per day, up to 2 weeks. Please don't give them more than 2 weeks. Then should be stopped to avoid epithelial toxicity. The epithelial toxicity may be mistaken for persistent ulcer. So positive fluorescein stain could be an epithelial defect rather than dendrite or infection, I mean. Other topical eye drops preferred to be preservative-free, like antibiotic, lubricant, eye drops, and gels like hyaluronic acid, cyclopentolate to relieve pain and uveitis. Avoid steroid until complete recovery of the infection. Then we can consider low dose of fluoromethanol to reduce scarring with monitoring to avoid recurrences. Surgical treatment. Surgical treatment procedures for the corneal melting have happened. But it's usually uncommon with the viral keratitis, except with a severe disease with superadded infections like bacterial keratitis. So the PKP, if persistent corneal ulcer and inflammation, especially if superadded infection, as I mentioned, decide when there is thinning and the cornea is going to melt. Tectonic graft is a good step to eradicate infection and save the eyeball. The second surgical solution is for the corneal opacities left behind the disease. PTK, if superficial central opacity, decide with the corneal OCT if the opacity is less than 1/3 of the corneal thickness. KP is if full thickness. KP if full thickness opacities after stromal keratitis, I mean penetrating keratoplasty. No surgical intervention before a year of cure. Also, I have to say here that we can we go for the deep anterior lamellar of the opacity that is still away from the decimate. After estimation or identification of the depth of the opacity, we can decide for DALC or for penetrating keratoplasties. No surgical intervention before a year of cure and no recurrence at all. Also, put this patient on prophylactic systemic acyclovir, 800 milligrams a day for 1 month prior to surgery and then after the surgery as well. The surgical treatment, keratoplasties as DALC, PKP, the timing, I talked about it now. Prophylactic systemic, I talked about it. Yeah, the same. So the prophylaxis treatment will help prevention of complications expected after that, which is commonly happening if no prophylaxis and in the unsuitable time. If you are hurried to do the keratoplasty, you may get recurrence in the graft with the same sequelae. So finally, let's give the spot diagnosis for this picture and the upper one. What's your opinion? Try to say it before I say it. Yes, I heard you. Yeah. You actually, your answer is right. This is geographical ulcer. The upper photo is for geographical ulcer after mistreatment with the steroid. What about the photo down right? Yes, you said adenoviral keratitis, but it's not. It's the same like adenoviral keratitis, but adenoviral keratitis is fainter, dispersed, and it's subepithelial. But this is the macular corneal dystrophy. What about the photo on the right? What about the down photo on the left side? No, sorry, it's incorrect answer. You said epithelial erosion. It's not, but actually it is the fingerprint epithelial dystrophy, which is one of the genetic dystrophies of the cornea. So I'd like to thank you so much. Please, if you have any question about this presentation, please give them in the comments. Thank you so much and see you.